There's a lot of evidence, and I know many of us here in the room either come from the violence prevention field or the mental health field, and I'm sure everyone is quite aware of the evidence suggesting that experiences of intimate partner violence contributes to a range of adverse mental health outcomes, including anxiety, depression, post-traumatic stress disorder, and at its most extreme, suicidality. But as a reverse pathway, there's also increasing evidence that poor mental health can be a significant risk factor for both perpetrating and experiencing intimate partner violence. And so this review examines this latter pathway, which we think there's less attention to, and focusing it on our intimate partner violence and the potential role that improving mental health, even at a wider population level, including among men, could play as a prevention strategy of intimate partner violence.
Based on my work and my experiences with the Friendship Bench, I thought it would be important to start with a bit of the context of the country. I know most people, when they read about low-income countries, we talk about the mental health treatment gap that is there. So Zimbabwe is one such country that has a similar treatment gap of about 70%, meaning 70% of people who need to receive the mental health care do not get it for various reasons. And one of those reasons is, despite being a country of 15 million people, there are only 19 psychiatrists in the country and just over 35 clinical psychologists. So the Friendship Bench was founded in Zimbabwe, and this was out of a psychological crisis that had happened in the capital city of Harare. And the intervention was started by Professor Dixon Chibanda. Most of you might have read about most of the work that he has done. And he started working with community healthcare workers. So generally, the community healthcare workers in Zimbabwe are elderly women. So the Friendship Bench model is basically problem-solving therapy, where the grandmother sits down on a bench, a wooden park bench, at a primary care facility or within the community. And they sit down, they have about 6 sessions where they're going through the 6 steps of the problem-solving therapy, which include identifying a problem, making a problem list, identifying a problem, setting goals for each and one prioritized area of the problems, and also strengthening the mind, opening the mind, and strengthening the mind. And once somebody has come to the bench and has had sessions on the bench, they are then invited to join a peer-led support group, which we call Sekrubatanetose. And the primary outcome of or goal of the peer-led support group is definitely to be therapeutic. But I think over the years, it also addresses one of the drivers that Dr. Erin was talking about, the issues to do with poverty and food security, because we have found that because of the element of behavioral activation that the peer-led support groups have, the initial groups would do crocheting, but eventually these sort of behavioral activation activities evolved depending on community needs, such that others involve themselves in things like gardening, others do baking, and it differs. But it has also become a very huge source of income, which actually addresses some of the problems that some of the clients come with on the bench. We did a 1-year follow-up, and it keeps showing that the intervention is successful, and there's sort of lots of changes that have been going on. Having shown all the success in Zimbabwe, initially in just one town, there has been a lot of scale-up, initially a geographical scale-up in Zimbabwe, where we're going in different provinces. But this has been made possible by the different partnerships that the Friendship Bench has. And like I said, one of those biggest partnerships is the government of Zimbabwe, the Ministry of Health, where the Friendship Bench intervention is recognized as an intervention that can be scaled to address some of the mental health challenges in Zimbabwe. And this has resulted in one of the biggest projects that the Friendship Bench is currently embarking on with the WHO under the WHO special initiative called the Friends Program, which will see, continued scale up of the friendship bench in Zimbabwe.
So the first is this element of providing training and support. So although the strategies outlined in this review can be provided by lay providers, they don't need to be provided by trained psychiatrists, it's still critical to think about how to ensure quality and needed training. I think another really important implication for practice with this work is to address stigma. There's a lot of stigma of mental health that exists in nearly every setting. And I think it's really important to think about how you're framing these interventions, especially if it's an intervention designed to explicitly improve and address common mental health symptoms. And this can also be really important in terms of acceptance of programs, how we frame programs. It's helpful to identify how strategies to improve mental health can either reinforce or challenge some of the harmful gender norms, and how this might be linked to risk factors as well for intimate partner violence.
This is how you can stay connected with us, and we look forward to seeing you again on some of our other webinars and offerings. So with that, thank you and see you all.